What we see now currently in the market is some new entries to the market have fully embraced this value-based care model, and oftentimes will provide that care in the home.
Welcome to the Business of Healthcare podcast from the Center for Healthcare Leadership and Management. The center is based at the Naveen Jindal School of Management at the University of Texas at Dallas. The show, like the center, brings together business leaders and other forward thinkers to discuss how best to meet the challenges of a rapidly changing, increasingly complex healthcare industry. I'm your host, Dr. Bob Kaiser, Director of the Master's Program in Healthcare Leadership and Management for Professionals. Today, we welcome Dr. Matt Lambert, Chief Medical Officer of Washington, D.C.-based Curation Health. The mission of Curation Health is to empower healthcare provider organizations and health plans to successfully navigate and scale from fee-for-service to value-based care. Welcome to the Business of Healthcare podcast, Matt.
Bob, thanks for having me.
Matt, you are known as an author and a subject matter expert in the area of value-based care, and there are so many paths we can go down on this topic. I believe that a large portion of our listening audience have heard the terms of value-based care and fee-for-service, but for their benefit, let's start our discussion from a historical perspective and try to frame these terms within a context of change and acceptance. So, what is value-based care, and when did it become an element of our healthcare environment?
Yeah, that's a great question. And VBC, value-based care, I think the term has been thrown around so much that not only maybe some, and it's relatively new, so maybe some folks don't even know it, but also I think it's getting diluted a little bit, and it means a lot of different things. So I always enjoy or an opportunity to talk a little bit more in the details about it. But I think we'll start by in the beginning, right? That's always a good place to start. And we'll start at Baylor. We'll start in 1930. Up until that time, healthcare in this country was charity work, and that's why so many hospitals were doing it. So it was charity work or affiliated with religious organizations, and sometimes it was cash for service, right? If you had cash to pay your provider, you would do that. But even back then, hospitals were struggling, and Baylor Hospital was struggling as early as 1930 to manage its business. So one of their administrators had a background in teachers union there in Dallas, and reached out to them and said, let's start up a payment structure so that you can, if you need hospitalization, we can guarantee you have that. And that's how Blue Cross came about. And it was associated with the teachers union there in Dallas. And it was 50 cents per member per month. So it was a subscription fee, essentially a value-based care payment model in 1930 to help them balance to help Baylor balance their books and to help provide some access for providers for teachers when they got sick. And then it just grew in every possible direction from there. So let's take 30s, 40s, and 50s. It spread to other different professions, and that's how it really became attached to your employment. And we're still the only industrialized nation that attaches your healthcare to your employment and all the good and bad that comes with that. But it was easy to do. Instead of selling to individual members, you went to the HR department at Ford, or you went to the HR department at Boeing, and you sold one insurance plan to them and all their employees. So it was just a really good way to grow the model. And they could attach it to to other forms of insurance, life insurance, and the insurance system really grew. And that widened the gap. Instead of narrowing the gap, it widened the gap between hospitals and insurance companies. The mid-60s come around, we get Medicare and Medicaid, and we get coverage for those who either retirement age and too old to be employed, and we get for those who are maybe not employed or have some disabilities on the Medicaid, and so we get payments for those. And so it continued to grow. I think most importantly, continued to get more expensive. So around in the mid-90s, we decided that we were going to do a couple things that really changed it. Number one, we were going to attach it to the federal budget, and especially Medicare and Medicaid payments. And they've been setting the rates, and the commercial insurers have been following ever since then. But that just made it political from day one, right?
Is that where fee for service comes from?
Yeah. The fee for service payments. Ross Perot was the guy who first figured out, because they thought, how are we going to set this up? But nobody really thought it through on how we're going to manage all these claims. And Ross Perot was working at IBM at the time and saw an opportunity and started up Perot Systems. And he was really the one who first managed fee for service Medicare claims. And at that point, the fee for service for Medicare was, quote, your usual and customary rate. There were no price controls on it whatsoever. Come the mid-90s, we attached it to the federal budget, and we also codified it. And that's where the E&M language, evaluation and management, came in. That said, more than happy for you to take care of these patients, to take care of folks, but you're going to have to check these boxes in order to get reimbursed for that care. And that came from the government first. And then of course the commercial plans adopted that. But that really drove us into, and I think the other thing that we did is we really incentivized procedures over holistic care, right? Over preventative care, over primary care, and especially over behavioral health. So when we pigeonholed providers and healthcare organizations into providing care a certain way in order to get compensated, that kind of got us stuck where we are now, and the things just gotten more and more expensive.
So fee for service is more, I think of it as a transaction then. It's basically the volume of the business you do times the price. And the more you do, the more money you make. So I'd say code up as much stuff as you can, as often as you can, and you'll make more money there. So it's really transactional. This concept of paying for value, a value-based environment, that's something different, isn't it?
Yeah, it is. It is. And Bob, I'm just going to take us back 1 second before when you talk about transactional. It is. It's. And I'll just use the comparison of a credit card swipe, right? Every time there's a transaction, and that opens up a whole nother part of tracking these transactions that adds to the cost, right? I mean, when you can think of any, think of a credit card company. Think of, they get, a cent on a transaction. That contributes to the total cost of care, measuring this at each transaction. And not only that, there are 10 different ways to do it, right? There's one method for Medicaid, there's one for Medicare, there's one for Aetna, there's one for Humana. That all creates all of this revenue cycle is the term for managing the bill. And the revenue cycle contributes to about 20% of healthcare costs. And when you look at the biggest difference between what we do in this country and what other advanced nations do, provide care less expensively, that's the biggest difference. So value-based care, we're taking out that credit card swipe. We're taking out that transactional fee. And we're really kind of mimicking what other nations do. And they're saying that based upon, and this is where this population health term comes around, right? All right. So based upon your population of patients, based upon everyone who lives in I'm going to say Anaconda, Montana, right? We looked at them and based upon their chronic conditions, we think it's going to cost, and I'm just going to pick a number. I'm going to say it's going to cost $10 million to manage that patient based upon what we think, based on how old they are, based upon what chronic conditions they have, and that. And so value-based care payments say, we're going to just pay you that $10,000 prospectively up front. And in this country, sometimes you hear per member per month. So that payment might be broken up per member. Sometimes you might even hear per member per year. In Canada, the federal government just pays each province a lump sum at the beginning of the year based on what they think the outcomes and costs are going to be, and say, use that money to care for your folks any way you can.
A universal budget of sorts.
Correct. So it takes out the transactional costs associated with that. It takes away the certain behaviors that you have to do to get compensated, right? I don't have to have you come into the visit. I don't have to have a chief complaint, a history of present illness. I don't have to do a 6-point physical exam and 5 review systems. It allows me to, I can solve your problem with a text message and a phone call, then I've just done that with zero margin, right? We provided care for you with zero margin. So it opens up those things. It puts a premium on information sharing, right? You've got to be able to communicate better. And we've advanced so much in the last 100 years and, ways that we can communicate. I could list 100 ways that we can communicate better with patients, with providers, with other health systems. It puts a premium on team care. So we don't have to have the doctor running the ball on every play. Sometimes it's probably most efficient to have my medical assistant manage something, or have my office staff manage something else, or have a colleague manage something else.
So back in, I guess, 2008, the Institute for Healthcare Improvement, they came up with this concept called the triple aim.
Yeah,
we had this triple aim, and what we want to do, we want to look at this thing you called population health. That's one of the elements. And then the per capita cost, and then the experience of care. So those 3 things kind of became a definition of a value-based system. And then afterwards, like years later, they said, let's make this a quadruple aim instead of a triple aim. And let's go ahead and pull in this whole concept of improved clinical experience. So when we start to talk about this value-based payment and value-based care, does this apply only to the Medicare world, or does this apply to the general population? And is it just for primary care doctors? How broad of acceptance do you see this taking place?
Being the largest health insurance company in the country, which CMS is, United, I think, is a close second now. But they're always trying some payment experiments and new models to get more towards that quadruple aim. So they set a lot of these programs and set a lot of these innovation programs. I'll call them the CMMI. It's a good example of that. The Center for Medicare and Medicaid Innovation. And so they're just looking for new ways to do this in a way that gets better, that achieves the triple and the quadruple aim. Typically, the commercial payers, so the Uniteds, the Aetnas, the Humanas of the world, will follow that in some form or fashion. And particularly with the Medicare Advantage plans, which is where the private insurance companies insure those who are 65 and older. They borrow a lot of this value-based care methodology to track their outcomes and to their expenses to do that. We'll also see it in the ACA, the Affordable Care Act, and some of those exchanges. There are a lot of value-based care methodologies there. So it tends to start with the federal government, and then different iterations of it spread out from there.
So primary care doctors, I think they're probably the classical fee-for-service measure, right? Most of them are kind of lined up that way. Yeah. How do we get them to go into a value-based environment? What are some of the hurdles and things that they have to overcome? And what are we doing to try to facilitate that?
Yeah, great question. We've gotten away from a lot of from emphasizing primary care, right? Because some of the payment models emphasize doing things, and it's really cool, man. We've got new technology and new things that we can do to procedures that we can do to extend life, but the primary care is really the team that pushes as much of those poor outcomes and costs farther into our life as we can, so we can enjoy as much of a good life. So some of value-based care certainly applies to specialists, but most of it, I think, applies to primary care. What we see now currently in the market is some new entries to the market have fully embraced this value-based care model, and oftentimes will provide that care in the home. So think of a 60-minute visit by a nurse practitioner in your home, as opposed to a 12.5-minute crunch in the office, where you get to know not only the patient's chronic conditions, you get to know a little about their needs. You certainly get to know about their social environment. And I think we'll probably talk a little bit more about how this social determinants of health all pull into this. But the ones that are embracing the model fully and have their compensation for their providers kind of baked into that, or you start that line of work expecting that I'm going to behave as a part of this care team providing value-based care, they're the ones who are really doing it, really moving the market a lot faster. And it's funny, house calls. I'm old enough to, as part of my training, I did a couple house calls, and you go out and you didn't do much. You took some vital signs. You listened to the patient's heart. You talked to him a little bit. Maybe gave him a shot of penicillin. Maybe got a slice of pecan pie in return for that. But we've kind of come back to that kind of model, to where there's the relationship and the understanding of the entire patient probably has more long-term value than that level 3 ambulatory visit. And if you set up the way you give this practice or adjust your processes to the practice, I think that's going to be what really drives it. Returning to some of the old ways is going to be, and seeing the value of the relationship.
This episode is brought to you by the Center for Healthcare Leadership and Management, the definitive resource for healthcare management education in North Texas. The center is based in the Naveen Jindal School of Management at the University of Texas at Dallas. It plays a unique role in training the next generation of healthcare leaders to meet local, regional, and national demands. The Jindal School uses its strengths in accounting, administration, finance, marketing, and information systems to educate highly qualified personnel for healthcare administration and executive leadership positions. The center is home to 7 healthcare leadership and management programs, including undergraduate and graduate programs, as well as executive programs for physicians and working professionals. For more information, visit us online at jindal.utdallas.edu/healthcare.
So looking at the high-tech involvement today, there's a lot of different tools and things that we're using. You talk about population health. Where does data fit into this picture of value-based care?
Well, yeah, great question. So one of the key areas of value-based care is information sharing, and that comes from data. And that's particularly clinical data, right? If you really want me to embrace value-based care as a clinician, you have to make it easier for me to access some recent pertinent information than to just order my own. So the best example is I have a patient in front of me who has abdominal pain. They need a CT scan. The patient says, you know what? I just had a CT scan across town 3 days ago. It has to be easier for me just to access that information, either through a health information exchange or through an integrated electronic health record, or maybe even from the payer, and get that information there, as opposed to ordering one myself, repeating an unnecessary test that's going to cost a couple $1,000s, and that's probably not going to yield any more to the outcome. So sharing, when I say value-based care puts a premium on sharing of clinical information, that's a pretty good example of it. Also, there are data sharing in between payers and providers. Going back to 1930 in Dallas and coming all the way back to 2021, there has been an increasing divide in payers and providers over the years. That's led to a lot of this. We're so disjointed in what we charge for care versus what we reimburse for care, and it's really created this adversarial relationship, and that's what makes healthcare economics so confusing. But sharing, coming back and around, if we're really going to do value-based care well, we're going to have payers and collaborate in a certain way again to really get value out of that. A good example is let's find things we can agree on. Let's make sure that everybody's got a colonoscopy every 10 years, right? It's going to catch cancers early. It's going to prevent some cancers. Provider organizations have a good interest in keeping their patients healthy, and payers have a great interest in keeping their patients healthy. And there are incentives from the government to make sure that patient's got a colonoscopy, and it benefits everyone. It benefits the patient, it benefits the provider, and it benefits the payer. So clinical sharing at the point of care, and then claims or quality sharing incentives at the point of care is really how we're going to push value-based care.
Well, the whole idea of quality improvement, I think it has to probably start. The quality really has to start with the provider and the doctors. And, today I think there's a lot of pressure out there. There's a lot of physician burnout. And if these things become complicated, these electronic health records and all this administrative stuff gets poured on top of the provider, that's where that concept of improved clinical experience comes in, a quadruple aim, not just looking at the cost and the population health, but actually looking at the clinical providers. And how do we make them get this easier than more difficult? What's required so that they don't get burdened down with more and more administrative things?
Yeah, I guess since I'm talking to a guy in Texas, I'll just use a football analogy. How's that sound?
Sounds good.
Yeah, block and tackle, man. Block and tackle. Make it simple. Most provider, you're not going to have any provider come out and say, I'm against quality care, right? It's just not, we're just not going to say that. So how do we define it? We do it on the things that we know are proven to improve outcomes. And things that our providers are comfortable with, and things that are easy for them to do. So, yearly screening for diabetic patients for certain things, cancer screenings for colon and for breast. We keep it really simple to those things that drive a lot of outcomes at a lot of cost and utilization. And we don't track it to death. When the meaningful use bill, high-tech bill came in, a lot of that bill was reporting to prove, and again, not to get too complicated, but the government paid you to adopt technology, and if you didn't do it, you were given a fine. And so, in order to make sure that was taxpayer money well spent, they put a little a stick there that said you have to report that you're using your electronic health record this much in order to do that. That made sense a while back. It doesn't make any sense anymore. So having providers still report on how they're using technology, I think, is a waste of time and effort, and really creates this. Let's focus on the patient. Let's focus on outcomes, and keep those quality rules concise and simple to things that have been proven to improve outcomes, and get some of the reporting out of it.
Well, we talked a little bit about population health, and really looking at that. Some of these providers today, they've got a panel of 400 patients. They have the Medicare Advantage program, and they give their patients their cell phone numbers, and they treat them as if they're VIPs. And they take such good care of their patients that the costs are really driven down, and the insurer likes that as well. Basically, they want to seek out these type of providers like that. We had mentioned in one of our previous podcasts, ChenMed, Dr. Gordon Chen, and how he was running that operation. And it seemed to be a fuel for growth. They could keep expanding and expanding because of their quality that they're creating, and their costs are going down further and further and further. And an element of that is really the social determinants of health that we hear a lot about today. Why don't you give us your perspective on how that figures in to a value-based environment?
Bob, thanks for bringing up ChinMed. And a dear friend of mine, a guy named Danny Guerra, is their CMIO. We worked together for years at Clinovations and at the advisory board. And so he's really shared with me a lot of what they do. And before I get to SDOH, or the social determinants of health, I just want to focus a little bit. So they do have smaller panel size. You can spend more time with your patient. But they do that, and they do that comprehensive visit earlier in the year, and they capture that risk assessment. Again, that risk that determines what that prospective payment to you is going to be. And then they touch their patients once a month for the rest of the year, but they don't charge for those services, right? That credit card swipe, that extra 20% of the cost added to it isn't there. So that's how they're able to do that. And that relationship over time, I think, really helps improve the outcomes. So now let's say we're a ChinMed or a ChinMed-like organization, and I've got a diabetic patient who's having trouble. They're eating too much fast food, and it's driving up their diabetes numbers, and it's going to lead to problems down the road. So now that I've got that prospective income, if it makes sense to do that monthly visit, I'm going to do that. But if it also makes time to buy some fresh food and have it delivered to that patient's home, then that's going to have a much better outcome than any medication that we can ever provide for the patient. And I'm freed up to spend that money for their care in an individualized way, because I'm not beholden to checking the boxes in order to get a fee-for-service revenue for that. So part of that really, the perfect model does not exist. But I think with the changes in technology and the changes in engagement and the changes of thought, where we start thinking about social circumstances, I think value-based care makes a lot more sense than some of the old fee-for-service ways that we were doing.
Well, when you can get the patient to care about themselves as much as the doctor cares about them, I think that education has a good return on investment for sure.
Yeah, it does.
So where do you think this is all going to go, Matt? What's your future view of where we end up as we move forward? I mean, you're there in Washington, D.C. You see where they make the sausage. There's a lot of things that are cussed and discussed when it comes to healthcare. And I know that somebody made a statement once that said that the only health policy issue on which Republicans and Democrats agree is the need to move from value-based to value-based payments. We really got to figure this thing out. What's your perspective being there in the midst of it all?
Yeah, let's back for your older listeners like me and you, remember when Congress was going to clean up baseball, right? So that gives you the if you want to say it, well, I'm against baseball, which nobody's going to say. So when you say value-based care, everyone tends to say, we're for value-based care, and that means sometimes it means different things. Sometimes it means federal programs, sometimes it means Medicare Advantage. But I think what we see is you can do value-based care as 20% of your current business and not change a thing. Right? You can have a few value-based care contracts, but still the majority of your business be fee for service, and just keep doing exactly the way that you've always done things. So we're kind of stuck a little bit at that 20% market share with value-based care, because in order to do that, you've got to get 2/3 of your patient in a value-based care program in order to realize the value of that. And that involves changing the way you deliver care. And that involves you thinking down the road a year and a half, which is tough to do if you're dependent on fee for service, or the cheeky saying for that is heads in beds, right? If you're waiting for people to get sick and come into the hospital in order to get your revenue, then it's hard to think a year and a half down the road. I think COVID's going to accelerate it. COVID, a lot of primary care struggled. ER, my clinical practice suffered because patients just stayed away. And so volumes diminished greatly, and therefore revenue diminished greatly, even though we're going to get caught up on the deferred care and delayed outcomes from a lot of this, I think. But if you were on a value-based care model, you got subscription per member per month. You got continuous revenue through the pandemic that allowed you to think in different ways, to plan farther ahead. And then about this time last year, I guess in April, when we changed all of the telehealth rules and all those regulations, which are still part of the public health emergency. Now I can engage patients by a text message, and it's part of my revenue package. I can engage them by a telehealth visit, and it's part of my revenue package. So I actually think COVID is going to help accelerate value-based care because of that steady revenue, even through a pandemic. So we just need to continue to incentivize health systems making that jump, providers making that jump, care members making that jump. I think we're going to continue to see incentives around that because you can continue to incentivize that without getting bogged down, I'll say, in the ACA arguments here in town, all the things about the Affordable Care Act. You can do this separate from that. So I think that's going to empower it. And then Medicare Advantage. Medicare Advantage is continuing to grow. And again, that's the private sector really pushing value-based care and senior folks. And I think that's going to be one of the biggest drivers too. So summing that up into one statement, Medicare Advantage and the experience from the pandemic are going to be the things that accelerate.
Very, very good points. Thank you for that. So I can't end the podcast without, I always ask the people about their company name, Curation Health. Why is the word curation there? And briefly tell us what that means and what you do there.
Yeah. So Curation Health, well, it's a term the kids use, Bob. Things are curated for us now, right? Your playlist might be curated. Your Netflix choices might be curated based on your previous viewing habits. So I guess it's a term, a term of the time. But we take clinical and claims information from the patient's previous history. And curate that down to whatever, not all information, we talk a lot about data, not all information has the same meaning in the value-based care world. So we curate that down to what exactly are the priorities for quality for this patient, and what are the chronic conditions that we need to manage for this patient. And we present that to providers at the point of care. So we get the best information we can so we're keeping our providers happy. We're integrating that as much as we can in the electronic health record because nobody likes to leave their workflow to do an extra task. And we help both payers and providers succeed in value-based care by using technology and integration to help that collaboration for it. So it's an exciting time. It's back to the future, as I've kind of talked about a little bit, as far as subscription models, per member per month models, and getting back to payers and providers working together the way they did initially intended to do this 100 years ago.
Well, Matt, I want to thank you for being part of our Business of Healthcare podcast. The things that we value at the university, obviously, we're lifelong learners just like you. We're wanting to continuously, learn, experiment, and develop ideas and share them and do that through a collaboration. So we're glad to have you collaborate with us on this podcast. And we look forward to more of your writings. We read your stuff out on LinkedIn. I know you have a couple books that you've already written. There's probably some more yet to be written. So thank you again for your time today with us.
Thanks for having me. I look forward to the next time.
Thanks for listening to the Business of Healthcare podcast. Join us online at businessofhealthcarepodcast.com to find episode links, notes, and more. Be sure to subscribe to the Business of Healthcare podcast on Apple Podcasts or your favorite podcasting app. To learn more about the Center for Healthcare Leadership and Management, go to jundal.utdallas.edu and then search under the Center and Institutes tab on the navigation menu. Also, we want to hear from you. If you'd like to provide feedback, make suggestions for future guests or show topics, or just want to get in touch with us, email us at healthcarebizpodcast@utdallas.edu. Biz is spelled B-I-Z. And let us know how we're doing. I'm your host, Dr. Bob Kaiser, with the Center for Healthcare Leadership and Management, where we're leading change by changing how we lead.